Good afternoon, everyone. Thanks for joining the 2023 MIPS Cost and Quality Performance Categories Overview webinar. During today's webinar, CMS subject matter experts will provide more information about meeting the requirements for the cost and quality performance categories, including participation basics for both performance categories, reporting and scoring requirements, and resources and support. The presentation will then be followed by a question and answer session where attendees will have an opportunity to ask questions through the phone and through the Q&A box, and CMS subject matter experts will address as many questions as time allows. Also to note, slide deck and recording from today's session will be posted soon. So with that said, I will now turn it over to Katie Moore from CMS to get us started. Katie?
Great, thanks, Matt, and good afternoon, good morning to everyone who's joining us today. Thank you so much for taking the time to listen to what we have to say today. And this is the third session webinar in our three-part webinar series we've put together. So we had an overview of all of MIPS about a month ago. And then a couple weeks ago, we dove into the promoting interoperability and improving activities performance categories. And as Matt said, today we are going to focus on our quality and cost performance categories. So we have, I know the MIPS overview webinar slides and information is all posted on our webinar library, and the promoting interoperability and improvement activities presentation should be up by early next week, I would think. So all of that, if folks need to reference, is available. And then we can go ahead to the next slide, please. Okay, so here's a quick rundown of what we are going to cover today. I will go over, as we always like to start our presentations, just to level set with everybody, because we know that we have a lot of returning folks that come to a lot of our different presentations and know the ins and outs of this program as well as we do. So, but we also always try to remember that sometimes we have new folks that are joining the program or just getting involved with the quality payment program. So we always like to start our presentations just with a brief overview of QPP as a whole, and then dig down a little bit more into MIPS and give a brief overview there. And then today we will cover everything you want to know about the quality performance category and cost performance categories. We'll also touch a little bit on facility-based scoring, because I know there's some questions out there related to that. And then we will leave as much time as we can at the end for live Q&A. Next slide. So real quick, just wanted to put these reminders out here. We've sent out listserv messages to let folks know that our MIPS exception applications for the 2023 performance year are available. So that's for our MIPS promoting interoperability, the performance category hardship exception application. And this gives folks the opportunity to request reweighting specifically for promoting interoperability performance category. And there's a list of different reasons why folks may need to request reweighting. And I know we say it in the further slide, but just want to call it here because we always get a lot of questions when we bring up the PI exception application. For small practices, the promoting interoperability performance category is automatically reweighted to 0%. So no need to submit an application if you are in a small practice. And then also we recently released our extreme and uncontrollable circumstances exception application that allows you to request reweighting for any and all performance categories if you face some form of extreme and uncontrollable circumstances, whether that be a natural disaster or something going on with your practice that is outside of your control. So a lot more information on what applies to those two applications on our website, on our exceptions application page. So encourage folks to check out that information. You have a lot of time right now. It's May. You have until January 2nd to get those applications into CMS, but just encourage you to check out more information on that. And I just wanted to call out, as we're going through our presentation today, if you keep an eye on the chat box at the bottom. Our wonderful support team online is helping to put in the different links as we're talking about these different resources or parts of the program to help guide you to where more information is on those different topics. So keep an eye on the chat box as we're talking. And one other housekeeping item is I just want to make sure folks know that we do have a QPP specific listserv. So if you aren't already signed up for that, I encourage you to get yourself or your practice signed up. That is our best way to communicate with clinicians on latest and greatest things going on with the program. So if you go to qpp.cms.gov, at the bottom of the page, there will be a box where to put in your email address. Next slide, please. And we can go ahead, one more. Okay, so if you have been working or participating in this program for a while, you've probably seen this graphic in a number of our resources, but it's just a real quick depiction of the quality payment program. So we were established from the Medicare Access and CHIP Reauthorization Act of 2015, which we refer to as MACRA. And it created the quality payment program, which is composed of 2 tracks. So the one we're focusing on today is MIPS, the Merit-Based Incentive Payment System. But there's also a second track to the program that is for our advanced alternative payment models. So I think the next slide, I'll give you a little bit more details about that. Next slide, please. Okay, so this is a great breakdown of the overlap that we see in these 2 tracks. So there's 2 different ways to participate in QPP, through MIPS or advanced APMs. However, some advanced APMs are also participate through MIPS. So it all depends on if the APM entity has achieved QP status, so qualifying APM participant status. If you achieve full QP status, you are not required to participate in MIPS, and you participate through the advanced APM track of the program. If you achieve partial QP status, you have the option to choose whether or not to participate in MIPS. However, if you are in an APM that does not achieve QP or partial QP status, then you will participate in QPP, in the quality payment program, through MIPS, through the Merit-Based Incentive Payment System. Next slide, please. Okay, so there are 4 performance categories in MIPS. There's the quality performance category, improvement activities performance category, promoting interoperability, and cost. So the first 3, as you'll see on the screen, these are the performance categories that you as the clinician or teams working with the clinicians report the measure or activity or the data to CMS. Whereas the cost performance category, CMS collects that information and calculates the data on your behalf through admin claims. So each of those performance categories generates a score based on the data that is submitted to CMS, and that all adds up to 100 points for your final score for MIPS. And then MIPS has that final score equals out to a payment adjustment. Your MIPS final score determines whether you receive a negative, neutral, or positive MIPS payment adjustment. Next slide, please. Okay, one more. Okay, so this gives a little bit more detail on that score. So each of those performance categories also have a specific weight that is associated with it. And it has changed over years, or some years it's stayed the same. So it just depends on what gets finalized in our rules each year. So for 2023, which is the performance year we're focusing on today, the quality performance category is 30% of your MIPS final score. Cost performance category is also 30%. Improvement activities is 15%, and promoting interoperability is 25%. And then as you'll see at the bottom, The APM entity participation has slightly different weights, so 55% for quality, and then 0% for cost, 15% for improvement activities, and 30% for promoting interoperability. Next slide. And as I said at the beginning, we get a lot of questions about our redistribution policies for small practices. And this is specific to those participating in traditional MIPS and MVPs. So we just wanted to pull this together. Standard weighting for small practices, again, PI is automatically reweighted to 0%. And then so that those percentage points get shifted. 40% would be for the quality performance category, 30% for cost, and then those other 15 points get shifted to improvement activities. And then participating through an APP or through APP, it's 50% for quality and then 50% for improvement activities. So again, 0% for cost and 0% for promoting interoperability. Next slide. Okay, sorry, I think I misspoke on the previous slide and I said APP and meant APM. This is the slide for APP performance categories and their weight. So quality is 50%, and then 0% again for cost, 20% for improvement activities, and 30% for promoting interoperability. And again, just wanted to point folks to our QPP resource library to find more detailed information on the APP, where we have some webinars and presentations and different things that give a lot more details on what's required in the APP, but we're not going to go too much detail today on that reporting option. Next slide, please. Okay, this is just a quick graphic that shows you the timeline for MIPS. We always want to make sure we know what performance year we're talking about when we're asking questions about the program or discussing the program. So right now, today, we are talking about the 2023 performance year. So the calendar year we're in right now, this is where clinicians are caring for their patients, recording data during this full year. So January 1 through December 31st. And then beginning January 2nd in 2024, that's when clinicians and the staff that are supporting them or third-party intermediaries that they're working with begin to submit data to CMS. So that begins January 2nd. And then the deadline for submitting for 2024 will be April 1st. Again, we always like to encourage folks to submit early whenever we can, even though that is a ways away. But then that ends April 1st. And then a little bit later that summer, we provide performance feedback. So that's when you get information back from CMS on how you participated, how the data that you submitted to CMS calculated into your final score, and then ultimately your payment adjustment information. And then those payment adjustments based on how you participated in the program in 2023 and the data that was submitted to CMS in 2024, those payment adjustments, whether it is negative, neutral, or positive, go into effect in 2025. So January 1st through December 31st, 2025 are the claims that will be impacted by this performance year. Next slide, please. Okay, so there are three MIPS reporting options available for 2023. We are very excited that we have this new option. If you're newer to the program and you haven't heard about MIPS value pathways, or we refer to as MVPs, this is a new option just beginning in 2023. We've been talking about it for a couple years as we've developed this new way of reporting and participating in MIPS. But this is the first year we have MVPs finalized and available for reporting. And it really just offers clinicians a subset of measures and activities that are relevant to their specialty or condition around a certain condition, and just really focus on how they practice. We're not going to go into too much detail because we could spend the next hour just talking about MVPs, but there are 12 available for 2023. Advanced registration is required, so encourage folks that want to learn more about MVPs. We have an entire webpage that tells you everything you need to know about MVPs, how to get involved in this new way of participating, and video on how to register and all the information you need. So encourage you again to check out the website. And then as we still have even though we have this new option for MVPs, we still have traditional MIPS available to clinicians. So this is historically how clinicians have participated in the program as we've gone through in previous slides. So that is still available and has not gone away. And then we also have our APM Performance Pathway, or APP. So the APP is really designed to reduce reporting burden and again, to encourage participation in advanced payment models, alternative payment models. So encourage folks to learn more about those different reporting options. Now is a great time so you know what you need to be collecting ahead of data submission in 2024. Next slide. Okay, now that we have our basics and overview of the program, I'm going to hand it off to Lisa Marie Gomez, who's going to go into a lot more detail on our quality performance category.
Great, thanks, Katie. Next slide, please. So the quality performance category assesses the quality of care clinicians deliver as evidenced by their performance on quality measures. The quality measures are tools that help us measure health care processes, outcomes, and patient care experiences. As you will see here, there are different words that you see, like behavioral health, chronic condition safety. These are what we consider priority areas for our program. So a lot of our measures may relate to these particular topic areas. So these are also topic areas in which are priority areas in which we're also seeking new measures, because we want to make sure that we adequately are able to assess performance based on these priority areas. Next slide, please. So every year on an annual basis, we update our MIPS quality measure inventory. So for the 2023 performance period, we have a total of 198 quality measures. These measures do not include the QCDR measures, or so as you will go into other slides, but so we have two sets of measures. So the quality measures and then the QCDR measures. So for the 198 measures, those include 9 additional quality measures, which includes 1 new administrative claims measure. Also part of our annual update of our inventory, we removed 11 quality measures. We also partially removed 2 quality measures. So what we mean by partially removed measures is that we remove the measures to be available from traditional MIPS, but they are available for MVPs. Also part of the inventory update, we had substantive changes to 76 MIPS quality measures, 5 of which will not have historical benchmark. Next slide, please. So this slide outlines the different types of quality measures that are available within the inventory. So the first one is process measures. We have outcome measures, intermediate outcome measures, patient-reported outcome-based performance measures, structure measures, patient engagement experience measures, and efficiency measures. So these are the types of measures types that we have within the program. And here on this slide, you can see the definition for each measure type. Next slide, please. So in terms of traditional MIPS, there are basic elements relating to quality performance category. So as Katie previously noted, for the quality performance category, it's weighted at 30%, which means it's 30% of your MIPS final score. So the quality performance category is weighted at 55% for MIPS eligible clinicians participating as an APM entity. For the quality performance category, it is a 12-month performance period. So it is from January 1st through December 31st of 2023. So in order to meet the requirements for traditional MIPS, clinicians are able, of the 198 quality measures, you're able to select 6 measures, because as a requirement, you're required to select a minimum of 6 measures. One must be an outcome measure or a high priority measure. A high priority measure falls within these categories. So it's outcome, appropriate use, patient engagement, experience, patient safety, efficiency care, care coordination, opioid related, and health equity related. If, let's say, there are less than 6 measures that apply or applicable to you, you're able to report on all the applicable measures that are applicable to you. As I noted, there are 2 sets of measures. There are the MIPS quality measure inventory, and then there's the QCR measures, which are also known as qualified clinical data registry measures. And these measures, there are 266 within our program. And with QCR measures, there's a separate process in which they are incorporated into our program. And then if you do not, let's say, select a measure within the 198 measure inventory, or let's say a QCR measures, you're also able to select specialty specific set of measures. And if, let's say, within your specialty set of measures, if there are less than 6 measures, then you report on all the measures that are available within that measure, that specialty measure set. Next slide, please. I just want to note that there's also measures that are available called the web interface measures. So the web interface measures are only available under the APP. Starting with the 2023 performance period, the web interface measures for groups and virtual groups participating in MIPS under traditional MIPS, they're not that collection type. The web interface measures are no longer available. As I noted, the web interface measures are still available for under the APP, which would be anyone participating, let's say, like, for example, shared savings program ACOs that are reporting under the APP, specifically web interface measures, that is available to you. Next slide, please. Now I'm going to review the quality performance category information relative to MVPs. So as a reminder, in order to participate and report through an MVP, you have to register in advance. And for MVPs, the quality performance category is at 30% of your final score. And for quality performance categories rated at 55% from eligible clinicians participating as an APM entity. The performance period is a 12-month performance period for MVPs. And for an MVP, you must select 4 measures that are available within your selected MVP. You must report an outcome measure or a high priority measure if an outcome measure is not available. A high priority measure falls within the following categories, which is outcome, appropriate use, patient engagement and experience, patient safety, efficiency, care coordination, opioid related, and health equity related. Population health measures are scored as part of the quality performance category. Small practices reporting Medicare Part B claims measures will meet quality reporting requirements by reporting all of the Medicare Part B claim measures available in the MVP, even if there are fewer than 4 measures. Next slide, please. So now I'm going to discuss just briefly scoring updates with regard to the quality performance category. So we're implementing several changes for 2023. The first one relates to measures that can be reliably scored against a benchmark will receive 1 to 10 points. Measures without a benchmark will receive 0 points. So 3 points for small practices will be applied in traditional MIPS and MVPs, even when data completeness and case minimum are met. So again, it's important that when you're reporting a measure, even if it doesn't have a benchmark, you must meet the reporting requirements. Otherwise, it will receive 0 points. Measures that don't meet the case minimum criteria will earn 0 points and 3 points for small practices. And measures that don't meet the data completeness criteria will continue to earn 0 points. So it's important that when you're looking at the measures that you want to report, to make sure that there is, for example, that there is a benchmark, and that if the measure that you do select and report on, it's important that you meet case minimum and data completeness requirements. And for small practices, as you can see, there are just a few minor nuance difference in terms of what is scored. And as I noted, small practices will receive 3 points, even if they do not meet case minimum criteria or if data completeness criteria is not met. Next slide, please. So on this one, I'm going to just go over achievement points for 2023. So measures can earn between 0 and 10 achievement points based on performance in comparison to a benchmark and the volume of data reported. Now with regard to bonus points, small practices are able to earn bonus points. For traditional MIPS, MVPs, and AVP, we will continue to add 6 bonus points to the quality performance category as long as 1 quality measure is submitted. I just want to highlight that if you're not a small practice, any other bonus points that we previously awarded are no longer applicable for within MIPS. So reporting an additional outcome measure or a high priority measure, you do not receive any bonus points, or also if you report measures that meet electronic end-to-end reporting criteria, again, there is no bonus points for that particular criteria. Next slide, please. Now I'm going to go into the quality performance category reporting requirements. Next slide, please. So I'm just going to briefly go over the collection types. So the collection type is the way in which clinicians collect data for MIPS quality measure. A MIPS quality measure may be collected in multiple ways, but each collection type has its own specifications. And these are measure specifications for reporting. And the collection type used has implications for scoring. So there are 5 collection types that are available for you to submit or to collect data for quality measures that you choose to report. So as you can see here, these are the collection types. So ECQM, a MIPS-EQM, QCR measure, Medicare Part B claims measure, and CAPS for MIPS survey measure. Next slide, please. I'm going to go over data completeness. So data completeness refers to the volume of performance data reported for the measure's eligible population. So data completeness is specific to Medicare patients for Medicare Part B claim measures only, and QCR measures, MIPS, EQMs, and ECQMs should include all payer data. When reporting a quality measure, your submission must identify the total eligible population, or denominator, as outlined in the measure specification. For small practices reporting Part B claims measures, we identify the eligible population based on the claims you submit. To meet data completeness criteria, you must report data, performance data, so it's performance met or not met or denominator exceptions for at least 70% of the total eligible population. And again, the total eligible population is the denominator. For the 2023 performance period, the data completeness threshold is at 70%. And this again relates to the QCR measures, MIPS clinical quality measures, which are MIPS EQMs, and ECQMs, which are electronic clinical quality measures. And again, for the MIPS EQMs and ECQMs, it's all payer data, similar to QCR measures. And it's also 70% threshold data completeness for Medicare Part B claim measures. And I just want to note that for 2024 and 2025 performance period, there will be an increase in the data completeness threshold, which will be at 75%. So I just want to give you the advance notice, which we had previously done in rulemaking. But just as a reminder, we will be increasing data completeness threshold starting next year. The measures that do not meet the data completeness threshold will earn 0 points. And as I previously noted, small practices will receive 3 points for measures that don't meet the data completeness threshold. Next slide, please. There are 4 MIPS quality measures that will be automatically evaluated and calculated through administrative claims in traditional MIPS. if minimum requirements are met. So these are the 4 measures in which are automatically evaluated and calculated if they are applicable. So the first one is the risk standardized acute cardiovascular related hospital admissions rate for patients with heart failure under MIPS. The second measure is the clinician and clinician group risk standardized hospital admission rate for patients with multiple chronic conditions. The third measure is the hospital-wide 30-day all-cause unplanned readmission rate for MIPS groups. And the fourth measure is a risk standardized complication rate following elective primary total hip angioplasty and or total knee angioplasty for MIPS. So these are the 4 measures that are automatically evaluated and calculated if they are applicable under traditional MIPS. Next slide, please. There are 2 population health measures that are available in MVP reporting. You select your preferred measure during MVP registration. So those population health measures that are available, the first one is the clinician and clinician group risk standardized hospital admission rate for patients with multiple chronic conditions. And the second measure is hospital-wide 30-day all-cause unplanned readmission rate for MIPS groups. We evaluate you on the population health measure included in your registration using insurance claims data. No additional data submission is required. If you don't meet the minimum requirement for that measure, we'll attempt to score you on another measure. If you can't be scored on either population health measures, the measure will be excluded from scoring. Next slide, please. So this slide just outlines what we consider like submitter type and who's submitting data and what, which is like collection type and how submission is reported. So here, when we think of like who, we think of like the submitter type, which relates to you, which is an individual, an eligible clinician, a group, a virtual group, or an APM entity representative. Also, a submitter type is a third-party intermediaries, which include QCDRs, qualified registries, and health information technology vendors, and CMS-approved survey vendors. When we think of the what, which is the collection type, as we previously noted, it's Medicare Part B claims measures, and the Medicare Part B claims measures are only applicable and available to small practices, ECQMs, MIPS CQMs, and capture MIPS survey measures. So those are the collection types, the what. The how, which is the submission type. And how you submit your measures is through your routine Medicare Part B claims billing practices. Also, it can be, you sign in to the Quality Payment Program website and you upload a QRDA3 file or a QPP JSON file. Or if you sign into the QPP website, you can upload a JPP JSON file. And again, it's all relative based on how you collect the data. So your submission type, again, how, which will be relative to your collection type or the types of measures that you are reporting through the program. And then an important element is when. As Katie previously noted, the 2023 performance period is now in 2023. And the submission period is the 3 months, or at least in the case of for next year, 2024, it's through April 1st. So it's basically a time frame after the close of the submission, the close of the performance period in which the submission begins. So for 2023, your submission of data would begin January 2nd, 2024, and it will conclude on April 1st, 2024. Next slide, please. Now I'm going to turn the presentation over to Zenobia Raspberry to go over the quality performance category scoring requirements. Not requirements, sorry, scoring policies. Zenobia, take it away.
Thank you, Lisa Marie, and thank you all for your attention. My name is Zenobia Raspberry, and I'm going to be going over our scoring policies for the 2023 performance year. Next slide, please. So as Lisa Marie previously mentioned, in the quality performance category, quality measures can receive between 0 and 10 measure achievement points. Here on this slide, we have a breakdown of how those achievement points are assigned. On the left, you'll see 1 to 10 points, and 1 to 10 points is assigned for measures in their third year or later, assuming that those measures can be reliably scored because they meet the data completeness requirements, have a benchmark, and the submission meets the case minimum. So those will be scored against the benchmarks from 1 to 10. Next, you'll see some of our special scoring policies for measures in their first and second years in the program. So starting here, we see 7 to 10 points. Those are for measures in their first year in the program. And at the bottom of that column, you see the measures for which that applies, which includes quality IDs 485 to 493, and the QCDR measures introduced in 2023. So measures that cannot be reliably scored because they do not have a case minimum or a benchmark will receive a 7-point flat score for measures in their first year. Those that can be reliably scored will receive 7 to 10 points based on performance against the benchmark. So measures in their first year, the lowest points you can achieve is 7 points. For measures in their second year, this changes to 5 to 10 points. So for measures that cannot be reliably scored, because they do not meet case minimums or have a benchmark, those will receive 5 points. And for those that can, they will receive 5 to 10 points. And those measures are those QCDR measures introduced in 2022, and quality IDs 481 to 483. And lastly, those measures being assigned 0 points are those that cannot be reliably scored, either because they do not meet the data completeness requirement or the case minimum requirement, or have a benchmark. And this policy applies to all practices except for small practices, because those will continue to receive 3 points. These scoring policies do not apply to administrative claims measures. We may gonna get more into the specifics of administrative claims scoring policies in later slides. But in the case that those do not meet the case minimum or benchmarking requirements, those are excluded from the quality score. Next slide, please. In MIPS, we do identify measures that the performance is considered topped out, and we consider performance topped out for process measures when the median performance rate is 95% or higher for non-inverse measures, or 5% or lower for inverse measures. And for non-process measures, the level of variance is less than 1/10. And the 75th and 90th percentiles are within 2 standard errors. Measures can also be considered extremely topped out if the average performance rate is 98% or higher for non-inverse measures, or 2% or lower for inverse measures. In the case of topped out measures, these can be considered for removal after 4 years as topped out, and extremely topped out measures can be considered for removal in the next rulemaking cycle. However, in certain instances, these measures can be and are retained. For measures that are designated as topped out for 2 consecutive performance periods, and these measures are identified as topped out in the benchmarks ahead of the performance year. So once a measure is identified as topped out for 2 consecutive years, In the second year, that measure has a 7-point cap applied, and they will be identified in the benchmarking files if a measure is topped out, and if that topped out measure has a 7-point cap applied. As a note, the QCDR measures are excluded from the topped out measure consideration. Next slide, please. So going through our benchmarking policies, our standard benchmark policy for ECQMs, MIPS EQMs, Medicare Part B claims measures and QCDR measures are based on historical data, and we use data submitted 2 performance periods prior for the 2023 performance year. That would be using data collected in 2021. If a measure doesn't have a historical benchmark available, we attempt to calculate a benchmark if that measure gets 20 different submissions that meet the case minimum. Administrative claims measures beginning in 2023 will be scored against performance period benchmarks. Next slide, please. Other benchmarks used in the program are flat benchmarks, and those are used in these listed measures here. Measure 1 for MIPS CQM only, and measure 236 for MIPS CQM and Part B claims. As a note, I didn't highlight it in the last slide, it was in that information, but benchmarks are calculated based on the collection type. So each collection type will have its own benchmark. So lastly, for the consumer assessment of healthcare providers and systems, CAPS, for MIPS survey measures, CMS will attempt to establish a benchmark for each summary survey measure. We will be using the 2021 data, our historical data, to calculate these benchmarks, and points will be awarded from 1 to 10 based on where performance falls in these deciles. And the final CAPS for MIPS score will be an average of the points across these survey measures. Next slide, please. So here we have a visualization of how these benchmarks are converted to achievement points, and how that relates to the different data completeness and submission case minimum requirements. So here, the first consideration is if a measure does meet data completeness requirement, meaning 70% of eligible population is reported for. And to reiterate that sort of first slide, for those that do not meet data completeness, they will be assigned 0 points or 3 points in the case of small measures. The next consideration is if the case minimum is met. And if the answer is no, and that measure has been in the program for 3 or more years, that will receive 0 points or 3 points for small practices. For measures in their second year in the program, it will just had a brain fart. But for measures in their second year in the program, those new measures, they'll receive 5 points, and in the first year, 7 points. And that is the same for measures that lack a benchmark. Lastly, we have our measures that can be reliably scored. And starting from those in their second year, they can receive between 5 to 10 points based on their performance against the benchmark. For those in their first year, 7 to 10 points. And third and beyond, 1 to 10 points. Next slide, please. If a measure doesn't have a benchmark and cannot be reliably scored, again, reiterating this, they will receive 0 measure achievement points for 2023, unless we can establish a performance period benchmark. And the requirements for that are to have 20 different submissions with that meet the case minimum. So in the event that does not happen, clinicians receive 0 points, except if they are in a small practice, they will continue to receive 3 points. And this applies to measures in MIPS and MVPs, except for admin's claims. Also, it does not apply to participants in the APP. And again, reiterating, those that do not meet data completeness will receive 0 points, except for small practices. Next slide, please. Lisa Marie stated this before, but no longer will we be offering the outcome and high priority measures in the quality performance performance category. The small bonus practice will still be available for the 2023 performance period. That is 6 bonus points that are added to the numerator of the performance category for clinicians and small practices that submit data on at least one quality measure. Next slide, please. In the quality performance category, we also offer improvement scoring, and clinicians can earn up to 10 percentage points based on the rate of performance from the previous year. And here below, you can see how that is calculated here. So the increase from the previous year is divided by the prior year performance and multiplied by a factor of 10 to give us the improvement score. Next slide, please. So here we'll see the breakdown of how the overall quality performance category score is calculated. So you have your total measure achievement points. So the sum of each individual measure score over the total available measure achievement points. And the total available points is equal to the number of required measurements. So in the baseline of 6 measures multiplied by 10. That's then multiplied by 100 and added to the improvement score to give the overall quality performance category score. And you see on the bottom an example of how that works out. Next slide, please. And this slide goes through the scoring for small practices, and you'll see here the difference is that small practice bonus is added in the numerator there. So as a reminder that small practice bonus is added to small practices that submit at least one measure. And the rest of the scoring is pretty much identical. Next slide, please. So here you see a breakdown of the total maximum points available. So as I said, the 6 required measures with no administrative claims measures applicable, the maximum points is 60. And you'll see that goes up as more administrative claims measures become applicable. As a reminder, those were the administrative claims measures that Lisa Marie went through in her portion of this presentation a few slides earlier. Next slide, please. And here we'll see the maximum points available in the MIPS program. So that's the 4 required measures plus the 1 population health measure that is chosen. Next slide, please. And here, lastly, we have our breakdown of the reweighting of the quality performance category. If you note the difference here in the event that quality is reweighted, it is all reweighted to the promoting interoperability performance category. Reweighting will occur in instances where there are no quality measures available, which is applicable in only traditional MIPS, or there is an approved EUC, extreme and uncontrollable application for the quality performance category. And that's it for quality scoring. Next slide, please. I will hand it over to Ray to talk us through cost.
Great, thanks, Zenobia, and hi, everyone. My name is Ray Dotel, and I am the cost measure lead here at CMS. We can go to the next slide, please. Okay, so for cost measures are attributed to clinicians according to each measure's individual specifications. Each cost measure has two specifications documents. The first is the measure information form, or MIF, which describes the methodology used to construct the measure. And then the second is the measure codes list. And this contains the service codes and clinical logic used in the methodology. And the 2023 MIPS summary of cost measures document provides an overview of all cost measures and is linked at the bottom of this slide. Next slide, please. So for the 2023 performance year, the cost performance category will account for 30% of your MIPS final score. Like quality, the cost performance category has a 12-month reporting period. So for 2023, the performance period is from January 1st, 2023 to December 31st, 2023. There are also no reporting requirements for the costs category. CMS will retrieve all cost data from your administrative claims. And in order to be scored on a cost measure, you or your group must meet or exceed the case minimum for that cost measure. And finally, you or your group can earn up to 1 percentage point for improvement scoring in the cost category for the 2023 performance period. Next slide, please. So for the 2023 MIPS performance period, there are a total of 25 cost measures. For traditional MIPS, you'll be scored on every cost measure for which you meet the case minimum. And for MVPs, each MVP includes a subset of cost measures applicable to the MVP's clinical topic, and you will be scored on every cost measure available within your selected MVP for which you meet the case minimum. Subgroups will be evaluated and scored on cost measures based on their affiliated group. And if you cannot be scored on any cost measure in an MVP, the weight will be redistributed to another performance category. And then finally, measures can earn between 1 and 10 achievement points based on performance in comparison to a performance period benchmark. Next slide, please. So as I mentioned before, there are 25 cost measures for the 2023 performance period. This includes the Medicare spending per beneficiary, or MSPB clinician measure, the total per capita cost, or TPCC measure, and then there are 23 episode-based cost measures. And again, CMS uses Medicare claims to calculate cost measure performance, so clinicians do not need to submit any data for the cost category. Next slide, please. Okay, so this slide goes into detail on the 25 cost measures available. Of the 23 episode-based cost measures, 15 are procedural-based, 6 are acute inpatient medical condition-based, and 2 are chronic condition-based. And as you'll see, this slide also documents the case minimums and data sources for the different cost measure types. Next slide, please. This slide, we have some of the features of cost measures defined. So payment standardization is the process of calculating standardized claim payment amounts for clinician resource use. Payments included in MIPS cost measures are payment standardized. Benchmarks are calculated for each cost measure, which are based on the performance year, not a historical baseline. And all MIPS eligible clinicians that meet or exceed a case minimum for a measure are included in the same benchmark. Attribution is the assignment of patients' treatment costs to clinicians. Each measure attribution method is detailed in the MIF, the measure information form. And then finally, risk adjustment is used to account for differences in patient characteristics, such as clinical risk factors that aren't directly related to patient care, but may influence the cost of care provided. Next slide, please. So now I'll review the 2023 cost measures. Next slide, please. So first off, we have the Medicare spending per beneficiary clinician measure, or the MSPB. This measure assesses Medicare Parts A and B costs incurred by a single patient during an episode window. For this measure, there is a difference between surgical and medical episodes. Surgical episodes are attributed to any clinician who performed any related surgical procedure during the inpatient stay and to the TIN under which the clinicians billed for the procedure, whereas the medical episodes are attributed to clinicians in two steps. The first being the episode is first attributed to the TIN that billed at least 30% of the inpatient evaluation and management services, or E&M services, listed on the Part B physician supplier claims during the inpatient stay. And then the second step is the episode is then attributed to any clinician in the TIN who billed at least one inpatient E&M service. And we can go to the next slide, please. So for exclusions for the MSPB, patients are excluded from the MSPB clinician measure if they weren't continuously enrolled in Medicare Parts A and B from 90 days before the episode start date through 30 days after discharge. They're excluded if the patient has a primary payer other than Medicare or is enrolled in Medicare Part C for any time during the episode window or the 90-day look-back period prior to the episode start date. Patients are excluded if there's no main clinician is attributed to the episode. The patients are also excluded if the patient's date of birth is missing from the source data. Patients are excluded if the discharge of the inpatient stay occurred in the last 30 days of the performance period. And then the final exclusion is the patients are excluded if the patient's death date occurred during or before the episode. And so episodes are excluded from the MSPB clinician measure if the index admission 1 didn't occur in subsection D hospital paid under the IPPS or acute care hospital in Maryland, and then also if they were involved in an acute to acute hospital transfer. And we can go to the next slide, please. Okay, for the case minimum, so the MSPB clinician measures case minimum is 35, which means 35 total MSPB clinician episodes must be attributed to a MIPS eligible clinician or group for the measure to be scored. For groups, a total of 35 MSPB clinician episodes must be attributed across all MIPS eligible clinicians who have reassigned their billing rights to the group's TIN. And then finally, a clinician participating in MIPS as an individual won't receive an MSPB clinician measure score if the clinician doesn't bill Medicare Part B physician supplier services furnished to patients during hospital stays, and therefore doesn't meet the case minimum. Next slide, please. So for risk adjustment, the MSPB clinician measure is risk adjusted to account for patient age, comorbidities, disability status, ESRD status, among others. And there's a separate risk adjustment model is estimated for MSPB clinician episodes within each MDC or major diagnostic category. And we can go to the next slide, please. Okay, so the MSPB clinician measure is calculated in 6 steps. So first, defining the population of index admissions, attributing the episode to a clinician or clinician group, excluding clinically unrelated services and calculating the episode's observed cost, then excluding episodes if necessary. Number 5 is then calculating expected episode cost through risk adjustment, and then finally is calculating the measure score. We can go to the next slide, please. Okay, so the next one is the total per capita cost measure, or the TPCC. This global measure measures the overall cost of care delivered to patients with a focus on primary care they receive from their providers. In this measure, the TPCC is attributed using 4 steps. So first, identifying candidate events based on the occurrence of certain primary care services that indicate the start of a primary care relationship. Next is applying service category and specialty exclusions to only include specialties and clinicians providing primary care. Next is constructing risk windows during which a clinician could reasonably be held accountable for the beneficiary's treatment costs. And then finally is attributing beneficiary months that occur during a risk window and the performance period to TINs and TIN MPIs. Next slide, please. Here we have the exclusions for TPCC. So patients are excluded from the TPC measure if they had a primary payer other than Medicare for any month during the performance year. They're also excluded if they weren't enrolled in both Medicare Parts A and B for every month of the performance year, unless part year enrollment was a result of a new enrollment or death. They're also excluded if they resided outside the United States or its territories during any month of the performance year. They're also excluded if they are covered by the Railroad Retirement Board, their date of birth is missing from data sources, or if they died before the start of the performance period. And specialty adjustment is applied to the TPCC measure to account for cost variation across specialties and TINs, and specialty adjustment is performed at the provider level. Next slide, please. Okay, so the case minimum. So for TPCC, the case minimum is 20 patients. The clinicians and groups will only be scored if they are attributed any month across at least 20 patients. And with regards to risk adjustment, a TPCC risk score is generated for each beneficiary month using diagnostic data from the 12 months immediately preceding each beneficiary month. And so, for example, to determine if the risk score for a beneficiary month of August 2023, the data from August 2022 to July 2023 would be used. And then a patient's risk score summarizes their expected costs of care relative to other patients. Next slide, please. Okay, so the TPCC measure is calculated in 5 steps. So first we calculate the payment standardized monthly observed cost. Then we calculate risk scores and risk adjust monthly costs. Then we specialty adjust monthly costs, and then finally we calculate the measure score. And when calculating the TPCC, the numerator for this measure is the sum of all risk-adjusted, payment standardized, and specialty-adjusted Medicare Parts A and B costs across all Benny months attributed to a TIN or TIN MPI during the measurement period. And then the denominator for TPCC is the number of Benny months attributed to a TIN or TIN MPI during the measurement period. And next slide, please. Okay, so next we have our episode-based cost measures. So for the acute inpatient medical conditions and procedural episode-based cost measures, they assess the cost of Medicare for the items and services provided to a patient during an episode of care. These types of cost measures only include items and services related to the episode of care for a clinical condition or procedure. For acute inpatient medical episodes, an episode is attributed to clinician groups or TINs that bill at least 30% of the inpatient E&M claims during the trigger inpatient stay into individual clinicians or TIN MPIs who bill at least one inpatient E&M claim line under a TIN that met the 30% threshold. And for some episode groups, additional codes aid in determining the attributed clinician. And for procedural episodes, they are attributed to the clinician who bills a trigger code for the episode group. And for clinician groups, episodes are attributed by aggregating all episodes attributed to clinicians that bill to that clinician group. Next slide, please. Okay, so for inpatient and procedural, for acute inpatient and procedural cost measures, they're calculated in the following steps. So first we have the trigger and the define an episode. And so episodes are generally defined by billing codes that trigger an episode, and episodes may be placed into mutually exclusive and exhaustive subgroups for meaningful comparison. Next, we attribute episodes to a clinician. Next, we assign the cost to an episode and calculate total observed episode cost. Then we have the exclusions, so measure-specific exclusions remove unique groups of patients from the measures in cases where it may be impractical or not unfair to compare the cost of caring for these patients to the cost of caring for the measured cohort as a whole. Then we calculate expected episode costs through risk adjustment, and then finally calculate the measure scores. And next slide, please. Okay, so the next few slides list out the 15 procedural episode-based cost measures and the 6 acute inpatient medical condition episode-based cost measures. And so I think we can go to the next slide too. So for each measure listed in this table, an episode is opened, or also known as triggered, by a certain clinical event referred to in the table in other documents as the trigger. An episode window may include a period of time before the triggering clinical event, and that would be referred to as the pre-trigger period, plus a period of time after the triggering event, which is the post-trigger period. And then some episode windows begin when the triggering event occurs and don't include a pre-trigger window. Therefore, those ones are listed with the pre-trigger period as 0 days. And the episode window used to calculate each of the episode-based measures is listed as well. And you can go to the next slide, please. And again, this is just listing out the 15 procedural episode-based cost measures and the 6 acute inpatient. Next slide, please. And one more. Okay, so for acute inpatient medical conditions measures, episodes are attributed to clinician groups that bill at least 30% of the inpatient E&M claim lines during the trigger period, trigger inpatient stay, and to clinicians who bill at least one E&M claim line under a TIN that met the 30% threshold. All TIN MPIs who bill at least one inpatient E&M service within a TIN that met the 30% threshold will be attributed the episode. So as a result, acute inpatient medical condition episode-based cost measures can be attributed to more than one individual clinician. And for the procedural episode-based measures, attribution is to any TIN MPI who builds a trigger code defined by the CPT HCFIX codes on the date of the procedure or during a concurrent related inpatient stay. And then as a result, procedural-based episode-based cost measures can be attributed to more than one clinician. And CMS doesn't exclude episodes if a patient already qualified for another episode. Next slide, please. Okay, so now for the case minimums. So the case minimum for the procedural episode-based measures is 10, meaning 10 episodes must be attributed to a MIPS eligible clinician or group for the measure to be scored. And for groups, a total of 10 procedural episodes must be attributed across all clinicians who have reassigned their billing rights to the group's TIN. And there is a note here, so for the colon and rectal resection measure, that one has a case minimum of 20 episodes. And then for the acute inpatient medical conditions measures, they have a case minimum of 20, meaning that 20 episodes must be attributed to a MIPS eligible clinician or group for the measure to be scored. And then for groups, a total of 20 acute inpatient medical condition episodes must be attributed across all clinicians who have reassigned their billing rights to the group's TIN. And next slide, please. And then finally, we have the chronic condition episode-based cost measures. So these measures are constructed and calculated via the following 8 steps. The first is to identify patients receiving care. Next, we identify the total length of care between a patient and a clinician group. Third step is to define an episode. And then we attribute the episode to the clinician group or clinician. Next, we assign costs to the episode and calculate the episode's annualized observed costs. Then we exclude episodes. Next, we calculate the annualized expected costs for risk adjustment, and then the score is calculated. Next slide, please. And so chronic condition cost measures have the following exclusions. So they're excluded if the patient is a primary payer, has a primary payer other than Medicare for any time overlapping the episode window or the 120-day look-back period prior to the episode window. There's an exclusion if the patient wasn't enrolled in Medicare Parts A and B for the entirety of the look-back period plus episode window, or if they were enrolled in Part C for any part of the look-back period plus episode window. There's also exclusions if the patient wasn't found in the Medicare enrollment database, if the patient's death date occurred before the episode end date, if the patient resided outside the United States or its territories during the episode window, and also if the patient has an episode window shorter than 1 year. Next slide, please. And so these are the two chronic condition episode-based cost measures available in 2023. They are diabetes and then asthma COPD. Both of these measures have a minimum episode window of 365 days. And clinicians and groups will only be scored on the measures if they're attributed at least 20 episodes for both of these chronic condition measures. Next slide, please. Okay, and now that's all I had for the scoring for the cost measures, and I'll now pass it to Christina to cover cost scoring.
Thanks, Ray, and good afternoon, everybody. My name is Christina Roberison, and I will be going over the scoring of the cost performance category. Next slide, please. So as Ray previously mentioned, we do not have any reporting requirement for the cost performance category because CMS uses Medicare administrative claims data to calculate the cost measure performance. And under traditional MIPS, clinicians will be scored on each measure for which they meet or exceed the established case minimum requirements. And for each MVP, because each MVP, includes cost measures relevant to the MVP clinical topics or episodes of care, then CMS will calculate the performance exclusively on the cost measures that are included in the selected MVP for which clinicians meet or exceed the established case minimum requirements, even if there are additional cost measures outside of your selected MVP that can be available for scoring. And we'll go over this a little bit on the next slide. Of note, subgroups will be evaluated for and scored on cost measures based on their affiliated group, and the APP doesn't have measures for the cost performance. Briefly, I'd like to go over how we assess our performance on MIPS cost performance measures, which Ray have already covered a little bit at the beginning of his sections. But essentially, we establish a benchmark for each cost measures based on the performance period. As Ray mentioned, there are no historical benchmarks established for the cost measures. And then we compare the performance expressed as dollar amounts on each measure to the performance period benchmarks and assign a 1 to 10 achievement points to each scored measure based on that comparison. And the amount of achievement points assigned to each measure is determined by identifying which benchmark decile range the measure's performance fall in. Next slide, please. So for each cost measures to be scored, an individual MIPS eligible clinician or group must meet or exceed the case minimum requirements, which Ray extensively went over during his section. But if one cost measure can be scored, then the measure score will be used to compute the performance category score. If multiple cost measures can be scored, the performance category score is the equally weighted average points assigned to the scored measures. And if no cost measures can be scored, then costs will count towards 0% of the MIPS final score, and CMS will reweigh the performance categories where Cost will be set at 0% because there were no measures that can be scored. And then quality will be set at 55%. Improvement activities will be set at 15%, and promoting interoperability at 30%. Next slide, please. So for the achievement points, as I mentioned, CMS will assign 1 to 10 achievement points to each scored measure based on the clinician or group's performance compared to the performance year benchmark. And achievement points will depend on which decile range that performance on the measure falls between. CMS will automatically re-waive a cost performance category for MIPS eligible clinicians affected by the extreme and uncontrollable circumstances policy. So if a MIPS eligible clinician is located in an affected area, then CMS will assume that the clinician doesn't have sufficient cost measures applicable, and we will assign a weight of 0% for the cost performance category in the final score, and follow the little graphic that we shared on the previous slide and how the weight is redistributed across the other categories. If other performance categories are reweighted, the cost performance category will always be weighted at either 30% or 0%, and CMS won't redistribute weight to the cost performance category for the 2023 performance year. It's important to note here that in cases where the cost and the improvement activities performance categories are the only 2 categories scored, then both categories will be receiving a weight of 50%. And also remember that an individual or group's cost measure performance is experienced as a dollar amount, and then again, we rank them, we assign the 1 to 2 achievement point and identify which deciles to set the score. Next slide, please. So that wraps up my section, and thank you for your attention, and I'll pass it back to my colleague Zenobia Raspberry, who will be going over the facility-based scoring section. Thank you.
Thanks, Christina, and hello again. I will be talking about the facility-based scoring. Next slide, please. So facility-based scoring is when a clinician or group has their quality or cost score assigned from the hospital value-based purchasing program, quality and cost rather. For this to happen, a clinician or group must be identified as facility-based. They must be assigned to a facility with a fiscal year 2024 hospital value-based purchasing program score, and the facility-based methodology score results in a higher final score than the final score calculated without the application of facility-based measurement. Next slide. And here on this slide, this breaks down what it means for a clinician to be considered facility-based. So starting with individual clinicians, it means that they billed at least 75% of their services in a hospital on campus outpatient or emergency room between October 1st, 2021 and September 30th, 2022. They have billed at least 1 service in an inpatient or emergency room in the same time frame, and they're assigned to a facility that receives a fiscal year 2024 VBP program score. Groups qualify for facility-based score. Groups and virtual groups qualify when 75% or more of the clinicians clinicians in the practice qualify for facility-based measurement as individuals. And the group is assigned a facility-based, assigned to a facility that receives a VBP score for 2024. Next slide, please. Individual facility-based clinicians automatically receive this quality and cost score if they don't submit data for performing operability or improvement activity performance category. or their practice chooses to participate in MIPS as a group. In this instance, the facility-based clinician will receive the higher of the two final scores. So either the group score or the facility-based score. And facility-based groups or virtual groups must submit data for the improvement activities or PI categories to receive the quality and cost scores for the attributed facilities VBP score. Next slide, please. That was it for facility-based scoring. If there are any additional questions, you can leave them in the chat. And now I'll turn it over to Katie for some help and support.
Great, thanks, Zenobia. Next slide, please. Okay, just a couple of things to go over real quick. I know we're running out of time here for the Q&A, but just a few tips to get started and familiarize yourself with the different resources and tools we have available. I know we've talked about a number of these during the presentation, so I encourage you to check them out. As always, we have our QPP Service Center available. Their email is below. You can create a ticket or call them. They have some really great agents available to answer your questions and get you help with participating in the program. Next slide, please. And again, just some more detailed information on MVP registration. It's open now through November 30th. So if you would like to participate in that way for 2023, please read through the registration information and get the registration in before the deadline. Next slide. The same thing for CAPS for MIPS survey registration. If you want to participate by working with a survey vendor to administer the CAPS for MIPS survey, that registration is open now as well, but they do have a sooner deadline of June 30th. So I encourage you to look through our different resources related to CAPS for MIPS survey. Next slide. Okay, just a number of resources, places to go to get more information. Again, I mentioned the QPP listserv to enter your email. Next slide, please. Okay, great. I wanted to get to this information. I know we're running out of time here, but just wanted to flag, if you haven't seen already, we put out a listserv message about this, and I believe there's a banner on the QPP website, but beginning on June 15th, we are going to start cleaning up our web pages, and that includes our resources, our webinars, and reports information that you have through the authenticated experience as well. We're going to start archiving all of the performance year information from 2017 through 2020. So this will help get in the research library specifically, but be able to get you the information you need more quickly, not having so much information out there kind of cluttering up the resource and webinar library. And it's really just best practices to keep to archive information. So wanted to give everybody a heads up that that is happening. You can still go in now. If there's any reports you want to sign in, your historical reports and download, we have a great step-by-step instructions on how to do that. If you want to do that and save that prior to the 15th, so through June 14th. Next slide. Okay, one more slide. Great, and that is it as far as information. I'm going to go ahead and turn it over to Ketchum team to see. I know we've been answering a number of questions through the QA, so hopefully we've gotten to a good amount of them, but we'll try and answer a few live here with the last few minutes of the webinar.
Thanks, Katie. Yeah, so we're going to jump over to the Q&A portion. And since when we are running down to the wire, we're probably only going to get a couple of questions in. Just as a reminder, you can drop questions into the Q&A box. I'm not sure we're going to have time to get to the live questions. However, I do just want to point out that if you do put a question into the Q&A box, we will be able to tell where it came from, and somebody from CMS can get back to you after the webinar. So I guess we're just going to jump right into it and look at the Q&A box. And we do have a question that asks, when will traditional MIPS no longer be a reporting option?
Hi, sorry, I couldn't get off mute there. So we have not determined when traditional MIPS will sunset and no longer be available. Our goal is to have enough MVPs available that there's enough choice for clinicians that apply to the majority of clinicians. But whenever we do set a date, it will be proposed through rulemaking and go through that formal rulemaking process. So nothing established yet, but will be through future rulemaking. Thanks.
Thanks. It does look like we have some people from our team answering questions as well. But we have one that asks, are there enough ECQMs available to support all required MVP quality reporting?
Hi, this is Colleen from the PIMS team. Currently, our inventory of ECQM measures do not necessarily lend themselves to have 4 ECQMs in each MVP. This is something we work to ensure can happen in the future. We would highly encourage all measure developers to submit measures for the ECQM collection type so we can achieve this. But at this time, again, the inventory does not necessarily allow for 4 ECQMs within every MVP.
Great. Thank you. So it does look like we have come up against time here. So I think that is all the questions that we're going to be able to take on this webinar. So I do appreciate everyone for all your questions, but we're going to turn it back over to Katie to wrap up the webinar.
Okay, great. Thanks, Matt. And again, apologize for not having more time here at the end, but hopefully you got a lot of your questions answered through the chat or through our different speakers today. Again, our QBB Service Center is available as well. So if we weren't able to get to your question and you need some assistance, I encourage you to submit it to the help desk and we'll be able to get back to you through one of our Service Center agents. So thank you all so much again, and we will talk to you next time. Have a great rest of the day.